Hello, my name is Michael Camilleri. I'm a gastroenterologist at Mayo Clinic in Rochester, Minnesota. I serve as professor of medicine, pharmacology, and physiology. For the last 30 years, I have studied stomach motility and the genesis of sensations of fullness, satiation, and appetite. In the last 12 years, I have studied the function of the stomach in obesity. Satiation is a sense of feeling full during a meal, which induces meal termination. The name of the article in Gastrointestinal Endoscopy is Gastrointestinal Traits, Individualizing Therapy for Obesity with Drugs and Devices, and the work comes from Mayo Clinic. In the next few minutes, I'm going to address 5 questions. First, how many people in the United States are potential candidates for obesity treatment? Second, how efficacious are current treatments for obesity? Third, what gastrointestinal dysfunctions are associated with obesity? Fourth, are these traits relevant to current treatments of obesity? And finally, are these traits relevant to endoscopically deployed treatments of obesity? So let's start with the first question. How many people in the United States are potential candidates for obesity treatment? The 2013 guidelines increased the number of adults recommended for weight loss treatment by 20.9%, from 116 million to just over 140 million. Second question, how efficacious are current treatments for obesity? There is regrettably an imbalance between efficacy and costs of commercial weight loss programs where the average weight loss is 2 to 3 kilograms, and drug therapy where the average weight loss over a 3-month period is around 5 kilograms. And this includes the drugs that were recently approved within the last year for the treatment of obesity, such as phentermine topiramate extended release or liraglutide. The most efficacious treatment is bariatric surgery, particularly Roux-en-Y gastric bypass and vertical sleeve gastrectomy. There has been a doubling of the number of bariatric procedures performed in the United States in the last decade, and currently around 180,000 operations are performed per year. What gastrointestinal dysfunctions are associated with obesity? We have identified quantitative traits that are regulated by the brain-gut axis in obesity. These can be measured reliably in humans, and they provide actionable approaches to control food intake. Thus, in a study involving 507 overweight, obese, or normal weight participants, obesity was associated with larger fasting gastric volume, accelerated gastric emptying of solids and liquids, lower postprandial levels of one of the satiation-associated hormones called peptide YY, higher volume of liquid calories that can be ingested to achieve a sense of comfortable postprandial fullness, and finally, a larger calorie intake in a buffet meal. When we apply principal components analysis, we identified Layston dimensions that account for approximately 81% of the variation among overweight and obese subjects. Thus, gastrointestinal and behavioral traits identify subphenotypes of obesity. The fourth question I want to discuss is, are these traits relevant to current treatments of obesity? The efficacy of bariatric surgery is attributed to reduction in the volume of the stomach, nutrient malabsorption with some types of surgery, increased postprandial incretin responses, and activation of farnesoid X receptor mechanisms. Similarly, the effects of medications may help us to select their use depending upon the traits that we identify in individual obese patients. Let me give you a few examples. In patients with accelerated gastric emptying, the class of drugs that might be most appropriate may be amylin agonists such as pramlintide or GLP-1 agonists such as liraglutide or exenatide, because these tend to delay gastric emptying. Second, if patients have enlarged gastric volume, we might choose ghrelin or motilin agonists because they reduce gastric accommodation. In contrast, The GLP-1 agonists, which tend to enhance gastric volume and increase postprandial accommodation, these may not be the preferred mechanisms or medications for patients with enlarged gastric volume. In patients who have prominent psychological disturbances or depression scores, these patients may be more amenable to treatments with centrally acting medications that may impact their affect, such as lorcaserin, a selective serotonin 5-HT2C agonist, which activates hypothalamic centers to reduce food intake, or the combination medication bupropion with naltrexone. And fourth, in patients with low levels of satiation or satiety, we might choose centrally acting medications that act on the hypothalamic nuclei of satiation, such as phentermine topiramate or the long-acting GLP-1 agonist liraglutide. These may be the drugs of choice in these patients who have low levels of satiation or satiety and who tend to consume more calories. The final question is, are these traits relevant to endoscopically deployed treatments of obesity? The approved balloon devices reduce the unfilled part of the stomach and are associated with a sensation of fullness or satiation. On the other hand, experimental therapies such as sleeve gastroplasty will reduce the size of the stomach, reduce the capacity of the stomach to accommodate food. And the duodenojejunal bypass liner, which is also an experimental therapy, has the potential to cause malabsorption. The precise effects of these devices and endoscopic treatments on incretins and on the stimulation of FXR receptor requires further study. So in summary and conclusion, the mechanisms or traits targeted by drug and device treatments include centrally mediated alterations of appetite or satiation, diversion of nutrients, and alteration of stomach capacity, stomach emptying, or the incretin hormones. In the future, we believe that treatment of obesity may be individualized based on the quantitative, gastrointestinal, and behavioral traits that are measured in obese patients. I want to thank you for your time, and I hope you enjoy reading the paper.